This is a 24/7nursetutors.com lecture. 24/7 Nurse Tutors, providing unlimited tutoring.
Welcome, and thank you for joining us. Pediatrics, Part 2.
Otitis media is an infection of the middle ear. The eustachian tubes are shorter and they get blocked. Symptoms include temporary loss of hearing, discharge from the ear, and fever, pulling at the ear after or it could accompany a common cold. When you see a young child pulling at the ear and acting fussy, these are two important signs of otitis media. Ask the parents about the presence of fever and night awakenings. Additional signs often observed in children with this condition include severe pain in the ear caused by pressure of fluids, fever, hyperthermia is possible, irritability, anorexia, continued symptoms of infection, decreased light reflex or tympanic membranes, and red bulging tympanic membrane upon otoscopy. Relieving pain is important. The symptom of pain and fever usually subside within 24 to 48 hours, but nurses must emphasize that the infection is not completely eradicated until all the prescribed medication is taken. Analgesic drugs such as acetaminophen or ibuprofen treat mild pain. Codeine is now recommended for more severe pain. Ice compresses placed over the affected ear may also provide comfort, reduce edema, and pressure. If the ear is draining, the external canal may be cleaned with a sterile cotton swab. These should be loose enough to allow drainage out of the ear. Occasionally, draining is so profuse from the skin surrounding the ear that it becomes excoriated from the exudate. This is usually prevented by frequent cleansing and application of virus moisture barriers or simply Vaseline. Prevention of reoccurrence requires adequate education regarding antibiotic therapy. Parents need to be taught ways to prevent otitis media, such as sitting or holding an infant upright during bottle feeding and breastfeeding. Propping bottles is discouraged to avoid the supine position and to encourage human contact during feeding. Parents must also recognize the initial signs of otitis media, such as irritability and ear pulling. Eliminating tobacco smoke and known allergens from the environment is also essential. Nursing interventions include educating the family in care of the child, providing emotional support for the child and family, administering antibiotics, and reducing temperature to prevent seizure. The signs of respiratory distress include color changes. The client becomes cyanotic. The accessory muscle use. The muscle of the neck appears to be moving when the client breathes. And respiratory failure will usually occur before cardiac failure. Bacterial tracheitis. Bacterial infection of the trachea can produce airway obstructions. Thank God this is uncommon, as it too can cause an airway obstruction like epiglottitis. Symptoms include a high fever, severe cough, difficulty breathing, wheezing, nasal flaring, cyanosis, and a blue tinge to their skin. Look at the chart on the video. They show the differences between epiglottitis, the croup, and bacterial tracheitis. Notice that there are many differences, but also many similarities. The anatomy, of course, all are different. The etiology, 2 bacterial, the croup being viral. The age range, much different, 3 to 7 years in epiglottitis, 6 months to 3 years on the croup, and 3 weeks to 16 years on brachial tracheitis. The onset, similar between the croup and brachial tracheitis, not so much with epiglottitis. The toxicity, marked with epiglottitis, mild to moderate with the croup, and mild to marked with brachial tracheitis. Drooling, absent with 2, frequent with epiglottitis. Cough, frequent with 2, and unusual with epiglottitis. Hoarseness, frequent with the croup and bacterial tracheitis, not so much with epiglottitis. And the white blood count will be normal with the croup. There'll be leukocytosis with epiglottitis and brachial tracheitis. RSV is a highly contagious disease and usually starts out as an upper respiratory infection, then progresses to respiratory distress and obstruction. RSV is the most common cause of bronchiolitis, an inflammation of the small airways in the lung, and pneumonia in children less than 1 year of age in the United States. It affects 2 to 6 month olds primarily. A child with RSV needs to be isolated, that's contact isolation, and monitored for respiratory status. Antiviral agents such as ribavirin aerosols and maintain patients' airways. In the hospital, some of the children that come in for treatment usually acquire the disease from an older child, particularly family members, daycare, or other places where we see lots of children. RSV is a communicable disease, and it can live on the skin or paper for up to 1 hour. While it is not airborne, once again, it is highly communicable, and meticulous hand washing is necessary. Highest infection times are winter and early spring. Medical therapy for RSV includes bronchodilators, steroids, beta antagonist, antiviral, virazole, prevention drug, Synagis, palivizumab, given IM, and Respigam, an RSV immune globulin, given IV, and Respigam, RSV immune globulin, given IV. The client will be on droplet and contact isolation. Asthma is a hypersensitivity response which is connected to other atopic conditions like eczema and allergic rhinitis. It is characterized by expiratory wheezing and coughing. Treated according to how many times they must use their rescue inhaler weekly and how often they are awakened at night with symptoms. All but the mildest stage require an inhaled steroid to minimize chronic lung changes according to the NIH. Look at the picture on the screen. Can you see the inflamed airway and also what a normal airway should look like? Now you understand why we hear the expiratory wheezing. The airway is very inflamed. Asthma is a condition characterized by intermittent airway obstruction in response to a variety of stimuli and allergens. Remember, asthma differs from COPD in that it is a reversible process either spontaneously or with treatment. The causes of childhood asthma are various. It could include allergens, smoking, beta blockers, dust, or even pets. Allergies influence persistence and severity of the illness. Once again, the signs and symptoms include tight coughing, expiratory wheezing, peak flow levels, usually checked 2 to 3 times each day, and monitor for respiratory distress. The emergency situations of asthma include acute episodes of reactive disease. Bronchioles may close rapidly, causing severe airway obstruction, anxiety, restlessness, and fear. Status asthmaticus, a medical emergency with severe edema, profuse sweating, respiratory failure, and some even die if it is left untreated. Class status asthmaticus is scary. I remember being in the ER and caring for a patient in status asthmaticus. Guess what, class? We had him intubated and he was still wheezing and in distress. There are many medications that are used to treat asthma. Let me tell you what happened to me once. My son has asthma. One summer while he was away at camp, the school nurse called. My son had ran out of his albuterol and was having a bad asthma attack. To be on the safe side, the nurse wanted us to meet her at the hospital. She should give him a drink that would help open his airway. Hey class, what drink was this? What do you think the drink was that I asked the nurse to give my son? It was hot coffee. Coffee has a similar nomenclature to theophylline. The good news is the nurse did not have to go to the hospital. My son was able to breathe and gave me more than enough time to drive up there and drop off his meds. Don't forget this. You can use it to save someone's life. Let's look at rescue meds used to treat asthma. Short-acting beta agonists, albuterol corticosteroids, and prednisone. Beclomethasone for short-term therapy. Anticholinergic agents like Atrovent. Remember what I taught you about anticholinergic? Anticholinergic dry up. Yes, SLUD. Salivation, lacrimation, urination, and defecation. Preventer controller medications include inhaled steroids like Advair, Pulmicort, Asmacort, mast cell inhibitors like Cromolyn, leukotriene modifiers like Singulair. Remember, you are more than a conqueror and you will be successful. Join me as we review core content in the next unit.